Good morning. Again, my name is Dora Hughes, and I'm the Acting Director for the Center for Clinical Standards and Quality and the Acting Chief Medical Officer for the Centers for Medicare and Medicaid Services, or CMS. I am so delighted to be here today to discuss how CMS is using our traditional coverage and payment systems in Medicare, Medicaid, and the marketplace health plans to identify and foster the connections between healthcare, public health, and the social services sector that can advance equitable solutions to improve health. I thought I'd start with a story that was shared with me by a colleague. It was a report of a young mother in Reading, Pennsylvania, who presented to the emergency department for the 17th time with her 5-year-old son. Always, it seemed, for non-emergent reasons. At this visit, however, through a CMS initiative, the family was screened for social needs. They were found to have housing difficulties, an unresponsive landlord, there was mold in the home, threats of utility shutoffs, including heat, and more. What was different about this visit, with CMS funding, the family was not only screened, but connected to the social service organizations, which were able to address their needs and assist them in finding a new home. My colleague reported that every day, the young boy would happily announce, "We're home, Mom," when they returned to their new place. But this is not only a heartwarming story about a young child. I'm sharing this because with their social needs being addressed, the mom reported that she was now able to attend to her own healthcare needs. And for the CMS initiative overall, across the 20+ sites over the 5-year implementation period, there is a statistically significant, an 8% decrease in visits to the emergency departments. And that has implications for quality, patient experience, and financial costs, both to the families, but also to our healthcare system. These are the types of connections that CMS is beginning to support. Community connections, because we know that where our beneficiaries live, where they work, where they learn, and where they age, all can have a profound impact, and in some cases, some may argue a greater impact on their health and longevity than clinical care alone. To be successful, CMS is increasingly beginning to partner with non-traditional, for us, community partners, in addition to or instead of clinical providers. I mentioned the connections with social services organizations in my first example. As a second example, CMS has another model initiative entitled Integrating Care for Kids, or INC. Through this model, CMS is hoping to better address the physical and the behavioral and mental health needs of children, in part by connecting with schools and child welfare services. In fact, one of our quality indicators, how we will judge if this model is successful or not, is the reduction of out-of-home placement or foster home placement of the children being served through this model. A third example would be CMS's recent announcement that in the state of California, CMS has approved a demonstration that would allow for the first time individuals who are incarcerated to receive mental health services in the period just prior to their release, with the expectation that this will help them establish connections to the community providers that can help them address their health needs, stabilize their health, and allow for a more successful reentry to community. This is a connection with the justice system through CMS's Medicaid program. This is so important, as the National Institute on Drug Abuse estimates that the rate of substance use disorders for people who are incarcerated may be as high as 65%. And these individuals are at increased risk of overdose in the first few weeks of reentry. For each of these examples, as you have heard, these initiatives rely on community partners, those frontline individuals who are members of or who have a deep understanding of the communities that they serve. CMS is increasingly connecting and integrating community partners into the broader health system, and we are systematically pursuing additional opportunities for doing even more so. Just last week, CMS finalized separate coding and payment for community health integration services, which include person-centered planning, care coordination, promoting patient self-advocacy, and facilitating access to the community resources to address unmet social needs that interfere with the diagnosis and treatment of our beneficiaries. Community partners are specifically included in this rulemaking. As one specific example, CMS will now be covering peer recovery counselors or specialists as part of our multi-pronged strategy to better address the behavioral health needs of our beneficiaries. In the months ahead, CMS will continue to incorporate non-traditional approaches into Medicare, Medicaid, and the marketplace to improve the health of Americans. Across our programs, we serve 160 million Americans, about 1 in 2 Americans, and thus we have a special responsibility and accountability to the American people for the work that we do. And thus, CMS will continue to expand and innovate and leverage creative approaches wherever we can to improve access to care and health outcomes. And this will include making connections between clinical providers and the range of community providers. I am eager to hear the additional ideas and recommendations that come forth from this summit. And I ask that you consider CMS a true partner in the work that you do in the days ahead. Thank you for your time today.